So I was fortunate to present the data from Keynote 671, which was looking at perioperative Pembrolizumab. And perioperative is this concept of giving neoadjuvant immune therapy followed by adjuvant immune therapy, as opposed to the other trials which have been done in lung cancer in the past, where there was a pure neoadjuvant trial and there have been a couple of pure adjuvant trials. So the study was designed to randomize close to 800 patients who had stage 2 and 3 non-small cell lung cancer, which was felt to be resectable, and that decision would have been made in a tumor board with surgeons saying, we think this is resectable. Patients were then randomized to either receive 4 cycles of cisplatin-based chemotherapy, which was based on histology either with gemcitabine or pemetrexed. And then the randomization was to either get Pembrolizumab at standard dosing 200 milligrams or to get placebo. After the 4 cycles, they then went to surgical resection and then continued on with either the Pembrolizumab or the placebo for up to 1 year. So the study was positive for event-free survival. The study was powered with dual primary endpoints, so EFS as well as overall survival. And at this first interim analysis, which was just over 2 years of follow-up, we had a very positive event-free survival with a hazard ratio of 0.58, highly statistically significant. We haven't yet crossed the significant boundary for overall survival, but we are seeing a separation of the curves, which is starting before the 24-month mark. And so things look promising there, but it's too early to say anything for sure. We'll be continuing to follow the patients who are enrolled on this trial. The endpoints are event-driven, and so at some point we will have enough events where we will be able to do the second interim analysis, which should be the final event-free survival analysis, and we'll hope that we'll see overall survival endpoint at that time as well. So we'll see what time tells. I will also mention that we did look at complete pathological responses and major pathological responses. Those, of course, were significantly improved with the Pembrolizumab, as they've been improved with the other trial that's combined chemotherapy plus checkpoint inhibition. So that wasn't surprising. We also did an exploratory analysis looking at for patients who either did or did not have those pathological responses, how did they do? And saw that whether or not there was a pathological complete response or whether or not there was a major pathological response, the patients who were on the Pembrolizumab arm did better, doing better with an event-free survival that was, again, you can't really call significance because that wasn't one of the primary things that we were looking at, but definitely encouraging. And this data speaks to the importance of us all trying to understand how do we cure the most patients, perhaps without over-treating. At this point, we've made significant strides with event-free survival hazard ratio of 0.58, which is really fantastic. And there are probably some patients who are getting more treatment than they need. And so those are going to be the challenges of the future trials as to who needs or doesn't need additional adjuvant treatment and who needs or didn't need any neoadjuvant treatment. And these are the big questions that we'll still have to answer. But for right now, this perioperative approach with Pembrolizumab was a statistically significant, clinically meaningful trial result, and we're hoping to see this be an option for patients.